Hello everyone. Welcome to the Pediatric Medical Emergencies presentation, Temple College, EMS. Respiratory emergencies. In this section, we're going to talk a little bit about airway obstruction, croup, epiglottitis, and asthma. These represent some of the more challenging cases that we can see with the pediatric patient. Okay, let's talk a little bit about this thing called partial airway obstruction. All right, so there may be a few causes that come to mind, such as a marble, a grape, something along those lines. What about some fluid that may have solidified, maybe mucus, something along those lines? But ultimately, partial airway obstructions may indicate, just as the name suggests, something is interfering with the airflow through the trachea, and sometimes we can identify the sound as it becomes turbulent through the trachea. The assessment of these particular patients is kind of straightforward. First of all, let's look at the patient. What's their positioning? Are they sitting upright? Sometimes leaning forward, they can try to position themselves where it's a little bit easier to breathe. What about their mental status? Remember, irritation, restlessness, those types of things, sometimes that's the earliest sign of hypoxia. What about if they're lethargic? So lethargy sometimes is associated with increased CO2. Again, the stridor, growing, the noisy airway, that may indicate some sort of a partial obstruction, especially as the turbulent air tries to move around the obstruction. What about retractions, especially on inspiration? Keep in mind that the trachea is somewhat flexible with some of these little guys. As they try to force air in, sometimes the trachea actually collapses on itself, further reducing the amount of flow. What about the peripheral perfusion? How does their skin color? What about the treatment? Well, the first one would be fairly easy to accomplish. Just make sure that they're positioned upright, position of comfort. Sometimes this involves making sure that they have a comfort, like a blanket, a stuffed animal. It could be a parent. Supplemental oxygen, especially if they're hypoxic. I think supplemental oxygen makes a lot of sense. In addition to maybe addressing the existing hypoxia, it might be a good idea to at least consider providing supplemental oxygen to build up a buffer. Sometimes when these children decide to collapse or deteriorate on us, we would like to have some sort of a buffer in place to kind of get us down the road a little bit as far as oxygen is concerned. What about the transport? And transport with these particular patients normally revolves around just doing anything we can to keep the patient calm and comfortable. These are the types of patients that sometimes you might have to reconsider running with your lights and sirens. That might aggravate the situation. Along the same line of thought, be cautious not to agitate the child, especially when you're trying to do your exam. This is the type of patient where you may need to create a rapport first. Sometimes start with the assessment at the feet and work your way up. But ultimately, just kind of keep in mind that aggressive evaluation may actually cause the patient to worsen right in front of you. Now, on the other hand, complete airway obstruction or partial airway obstruction with poor exchange. Now, these guys are kind of scary. Again, just looking at the overall assessment of these little guys, you may have some altered mental status. Whether or not that is the restlessness, irritability that may be associated with hypoxia, or it could be kind of that lethargic state that sometimes is associated with a high CO2. Again, you may listen. You might be able to hear, even without a stethoscope, the turbulence of that air trying to pass some sort of a partial obstruction. Now, the absence of any airflow at all, that might be a strong indicator that maybe we've got a complete airway obstruction. How do they look as far as respiratory efforts? Do they have the nasal flaring that's going on? Are they struggling? And just overall, do they have that look? What about their chest wall movement? Are we seeing any respiration? Are we seeing any movement in and out? Sometimes what we'll be able to see, especially with the severe respiratory distress with these little guys, is every time that the diaphragm tries to go lower, the chest actually will collapse in and of itself. So you can see the chest wall actually giving in to the negative pressure. And then, of course, the ominous sign, poor peripheral perfusion. That may be something that would be indicative of a situation about to get even worse. That may be the situation where the patient's starting to turn either pale in some circumstances, or blue, or cyanotic, maybe cool to touch, and ultimately to maybe a decreased pulse and or an extended capillary refill time. So one of the things that we like to talk about is just remember that there's a strong correlation between the bradycardia or slow heart rate with these little guys and hypoxia. That is, bradycardic pediatric patients are often bradycardic because of the hypoxia. So just kind of park that in your memory somewhere and just remember that key point. Then, of course, the treatment. So the foreign body airway procedures. We may try different procedures to try to dislodge that. What about suctioning? Suctioning may have a place, especially if it's something that you have the particular tools that you might be able to get a little bit deeper inside the back of the oropharynx and maybe pull out some thick mucus, some vomit, and so forth. Upper versus lower airway disease. Upper airway. Sometimes we can identify an upper airway obstruction or partial obstruction by stridor, some crowing, especially on inspiration. That is particularly pronounced as they try to take a deep breath and they have a lot of turbulence bringing that air through the trachea but around some sort of obstruction. Now the lower airway obstruction, that's where we can see or hear rather wheezing. How about the breathing efforts on expiration? So this would be like your asthma patient. We're going to get into a little bit later, but they have a prolonged expiratory phase as they're trying to blow the air out. It takes a lot of effort. What about the rapid breathing, especially without stridor? So this would be your patient that you don't hear any obvious obstruction. You don't hear any obvious turbulence in the airway, but they're just breathing fast. So this would be like your tachypnic patient that may actually be kind of quiet. Okay, so then there's croup. Croup is almost always a viral inflammation of the trachea and larynx. So that's one of the identifiers that we normally associate with croup, is that it's usually a viral situation. It usually affects the younger folks between 6 months and 4 years. It doesn't have to be within that range, but that seems to be where they are the most susceptible. Now, when you're taking a history and assessing the patient, you will usually hear something along the lines of, it seems to be worse at night. That seems to be a big telltale sign that is rather specific to the croup, or highly indicative. So when you have your scenarios and so forth in class, you may have that piece of clue that it's usually worse at night. So you can think about croup. The other telltale sign, something you can identify croup with, is that it's got a seal-like barking cough. And that's kind of one of those things that's kind of a giveaway whenever you see that on, say, an exam or some sort of an assessment, is when out of the blue they mention something like, there seems to be a barking cough, a seal-like barking cough, or something along those lines. So watch out for that indicator as well. And then, of course, the signs of respiratory distress. Once again, that may be increased respiratory rate. You can see that struggle on their face. You can see that they're gasping for air, maybe. And you could just also see that chest wall compliance, whether or not it's sunken in. Does it keep its form? Are they trying to pull up so much air that it creates a negative pressure and pulls the chest in? How's the trachea? Is the trachea collapsing on itself? Those types of things. Okay, so what are we going to do for croup? Well, the initial treatment, it's fairly common, fairly simple. Once again, pay attention to the position. Transport this patient in the position of comfort, doing everything that you can to prevent any type of agitation. Administer oxygen as much as tolerated. This may be one of those situations where you may just need to hold the mask close to the patient. Don't try to force the patient to have the mask. Avoid visualizing the airway. Obviously, that can be quite aggravating, so try to prevent that. If you've got the ability to provide cool air, that might provide a little bit of relief. Again, keep in mind that the back of the throat or the orphanx or maybe the trachea might be inflamed, so maybe a cool air, that seems to kind of help out ever so often. If you have the ability to humidify that cool air, that's another little technique that we've learned that might be helpful. And then, of course, your transportation. Again, transport in such a manner that you avoid any kind of excessive aggravation or anything like that that would cause the little guy or little gal to get excited. Okay, so then there's epiglottitis. Epiglottitis is the inflammation and then the swelling of the epiglottis. It's usually bacterial in nature. It usually affects the little guys and gals between 3 and 7. A big telltale sign for epiglottitis: sudden onset of high fever. So when you are assessing and getting the history, oftentimes if you can obtain some sort of a history where there was just all of a sudden a spike in the fever, it might be something to think about. The positioning on this particular patient is another one of those types of telltale signs. If you hear or see these little guys in what we call the tripod position, be very suspicious that maybe we've got something going on like epiglottitis. Again, the tripod position is a position where we naturally try to position ourselves where we can have the greatest amount of intrathoracic volume. We try to help ourselves by making it easier to breathe, and then we try to make it so that we can take in as much air as we can. So this is a position called the tripod position. Sometimes we'll hear about kind of a painful swallowing and respiratory distress. Again, these are the types of things that we might hear from the parent when the parent's able to say something along the lines of, yeah, the little guy was, kind of complaining or acting like there was excessive pain or additional pain as they were trying to eat or swallow some of the secretions and so forth, which kind of leads us to the next point with epiglottitis, which is the drooling. We oftentimes think that if it's difficult to swallow, then the secretions, the saliva, are going to need to go someplace. So they oftentimes just kind of drool out of the mouth. Again, big differentiators here: sudden onset of high fever, their tripoding position, some sort of a history or indication that maybe there was some painful swallowing, respiratory distress, and then of course the drooling. Big situation to watch out for. Okay, let's talk about the treatment for epiglottitis. Well, the first thing should be fairly obvious at this point. Place the position of comfort. We want to make sure that we don't force the child or the little guy or gal into any kind of position that would cause any aggravation at all. Administer high flow or high concentration oxygen. Again, what we want to be able to do is kind of minimize that hypoxia, that if it already exists or if it's emerging. But we also want to create a little bit of a buffer. That way, if we should have any deterioration or excessive swelling, then we've got a little bit of extra oxygen on board, transport immediately. That's going to be something that just want to just put out there, that this would be a situation that could deteriorate very, very quickly. And you don't want to just kind of waste your time in the house on this one. Do everything you can to decrease, especially just don't increase the child's anxiety. Don't place anything in the patient's mouth at all. So what would you do if the patient does deteriorate to the point where we may have closure of that glottic opening? So a lot of times what we would do is we would have to be kind of forced into providing ventilations. So the problem with providing ventilation for this particular patient is that a lot of that extra air is going to enter into the esophagus and go right into the stomach because of the occluded glottic opening. But the intensivists are actually pretty consistent in that good BVM technique. You can, to some degree, actually ventilate these little guys around the swollen epiglottis with good BVM technique. So it's just food for thought. Okay, then there's asthma. Normally it will affect about 7% of the children in the United States. We are experiencing a mortality increase. We have a number of potential reasons and a couple of ideas of why that is occurring. But ultimately, this is a situation where you have inflammation and or muscle spasm of the bronchioles. What exacerbates asthma oftentimes is that mucus secretion actually thickens. Remember, with asthma, somebody that is taking a deep breath and they're breathing fast, they actually have a situation where they lose a lot of fluid, so they could actually dry out their lungs, per se, just by trying to breathe fast and deep. So we call it insensible fluid loss. The fluid loss is kind of a double whammy because it causes the mucus to actually thicken. So that actually creates a situation where you can have a partially obstructed bronchiole, and in the really bad situations, you can actually have a fully obstructed bronchiole. So you get enough of those, you're going to be in trouble. So, okay. So what do we do about asthma? Well, obviously, we would want to help the patient breathe, and how we sometimes do that is we can give albuterol. That's a bronchodilator, and sometimes that helps to relax the bronchioles to a point where we can actually have some air move past that obstruction. Supplemental oxygen, again, if they're hypoxic and or struggling, it makes sense. Let's give them a little bit of a boost there. Word of a caution. So when we have these particular types of asthmatic patients, if you try to assist ventilations, it may be a situation where we're actually putting a lot of air into the lungs, and due to the disease process, we may not be able to get all of that air out due to the normal passive relaxation that is supposed to occur during exhalation. The problem with using a BVM is that you have to be on your A game. You have to remember that asthma is not a problem of getting air in, it's a problem of getting air out. So you will hear terms and concepts and ideas that are along the lines of, just remember, if you have to provide any mechanical ventilation, be sure that you extend the expiratory phase. So that may mean that you have to take a longer amount of time in between breaths so that that little chest can hopefully push some of the air out. Now, another ominous situation is what happens when the wheezing stops. So we have to make a pretty quick decision whether or not the wheezing going away is because of maybe the patient's getting better. Maybe we've got the airways opened up now, and maybe we've got good airflow. But the other scenario is ominous. What happens if we are so exacerbated, we're so tight that we now have no airflow? Both of those situations could potentially and theoretically result in kind of a silent chest or silent airflow. So in that particular case, you would certainly want to look at the overall clinical picture of the patient. If they look as though they are breathing better, we know which end of that spectrum we're at. If the patient is unconscious and comatose, turning blue and bradycardic, obviously we know that we are at the other end of the spectrum where the patient's in what we call peri-arrest. Okay, so for our practical purposes, we're going to want to try to categorize this respiratory dysfunction. The three main categories that we want to use will be respiratory distress, respiratory failure, and respiratory arrest. The difference between the three can be kind of summed up like this. So the arrest is just simply, there's just an absence of breathing. Respiratory distress is that particular patient that looks as though they are struggling. They can be struggling, but it looks like they're able to maintain adequate oxygenation. So they're just in distress. This may be the type of patient that is just that comes to mind that maybe is running around the emergency department. They're breathing fast. They're able to oxygenate. They're able to hold their own. Respiratory failure, on the other hand, would be when they are not able to maintain adequate oxygenation. This is your ominous sign. Unfortunately, for some of our patients, they go from respiratory distress into respiratory failure and then ultimately respiratory arrest. So I would recommend that you really spend some time and get the concept down between respiratory distress, respiratory failure, respiratory arrest. Let's start talking about the respiratory distress patient. This would be your patient that might be demonstrating some nasal flaring. Again, the nasal flaring may be a situation where they are intentionally opening up the nares to increase or maximize the airflow. Stridor or audible wheezing. So the stridor may be something where they are air hungry. They are really trying to pull a lot of air into and through the trachea. Again, if they're pulling a lot and we have any type of obstruction at all, you may hear some stridor. Or if they're just pulling so much volume that even just a clean and clear trachea could still give you some whistle and some stridor. What about the retractions? So do we have some intercostal retractions, which are between the ribs? So when they take a breath and they're kind of air hungry, you might be able to see the little spaces in between the ribs that actually get sunken in. What about above the clavicles? The supraclavicular retractions. As they try to take a deep breath, one of the things that they try to do is, again, create so much negative pressure that we could actually see some of these structures actually dip in instead of out. And likewise, below the ribs, the subcostal areas. As the little diaphragm tries to sink down, you can actually see where some of the area just below the ribs, just below the rib cage, actually gets pulled into the thorax. What about the use of the neck and abdominal muscles? So if they're using accessory muscles, that's usually an ominous sign. That may be an indication that the normal muscles of ventilation are getting tired. And what about the grunting? Grunting would be another type of a situation, especially for the little guys, the younger folks, the younger patients. As they start to grunt, we may start to think about maybe the grunting as a self-peep type of a situation, or a partially obstructed glottis. So respiratory failure. So we've moved from distress to respiratory failure. So now this patient may be that particular patient that's got some of these signs and symptoms, but ultimately they have the inability to maintain oxygenation. So some of the things that we might see with respiratory failure: tachypnea, cyanosis. Cyanosis would be a big indicator that we are unable to maintain oxygenation. Decreased muscle tone, so maybe a measure of flaccidity. Poor peripheral perfusion, again, that may be an indicator that we are peri-arrest. So that may be an extended capillary refill. That might be a slowing heart rate. Bad. Altered mental status. Again, this is probably your irritation, your restlessness for hypoxia, maybe some lethargy thrown in there as they start to become hypercapnic. Grunting, that again might be an attempt to create a little bit of PEEP, but it also might be a situation where we have some sort of a partially obstructed upper airway as well, maybe from just the relaxation of the muscles in the back of the oropharynx. Use of accessory muscles. So as the normal ventilatory muscles actually tire, we get into what we call exacerbation. So we have kind of a backup system. These are the accessory muscles. They don't last very long. So once you start seeing the use of accessory muscles, we really need to be aware and on top of the situation, because we are about to go into arrest. And this would be that golden opportunity for us to jump in and provide some support. And again, the retractions, we kind of talked about that on the previous slide. But as the negative pressure, intrathoracic pressure, exceeds or becomes greater, sometimes we'll see some of those softer structures actually sink in instead of raise up and out like they are supposed to when we try to increase the volume of our chest in order to bring in as much air as we can. Respiratory arrest. This is the patient that is not breathing or breathing so slow that there's no way that it would be enough to sustain life. So bradypneic patients, they might be breathing at maybe 3 to 4, maybe 5 times a minute. Obviously not enough to oxygenate the patient. You may also see that the patient is limp, so there's no muscle tone at all, so a complete flaccid type patient. Not a good sign at all. Then we have the unconsciousness, unconscious, unresponsive. That may be a strong indicator that we're not oxygenating the brain at all. So, ominous sign there. And then again, we have our bradycardia. Remember, bradycardia in the pediatric patient is strongly suggestive of hypoxia. So when you have your bradycardic patient, consider what is the hypoxic state or what is the oxygen status. Fix the oxygen, and many of these patients will rebound and actually have an okay pulse. But just remember, there's a strong correlation between bradycardia and hypoxia. A weak distal pulse. This may be of the situation where if the patient is shunting and or if the cardiac output is just so weak, maybe the blood pressure is so weak that we are not able to create that pulse wave at the distal extremities. So respiratory arrest, this is an ominous type of a situation. Not anything that would be a good day at the office at all. The respiratory treatment for some of these respiratory distress, failure, and or arrest patients. Number one, the high concentration oxygen. We'd want to provide some sort of supplemental oxygen to help these little guys out. If and when necessary, let's go ahead and ventilate, especially for the severe respiratory distress patient and or the bradypneic patients, and certainly for the respiratory arrest. And then, of course, if we have the situation with asthma where we have the bronchial constriction going on, let's go ahead and give some albuterol. That hopefully will open up the bronchioles enough to actually have some air movement. Let's shift our conversation to seizures. So a little bit of background information. Yes, they can be life-threatening. They're not always life-threatening, but they can be. They may be brief, prolonged, or really anywhere in between. Sometimes assessment is kind of difficult when you have a seizing patient, depending on what kind of seizure it is. They may have respiratory distress, or they may not have any respiratory distress at all. What about injuries that may be caused by the seizure? As a person is flailing about, they may strike a hard object, they may bite their tongue, those types of things. Just be considerate of the injuries that may be as a result of some of those motor movements. Along with your history, it'd be a good idea to get along with your assessment, it'd be a good idea to get a good history from either bystander, parents, family member, or whoever. Ask about a fever. A fever might be something to kind of think about and put a little bit of importance on. The fever in and of itself, we are finding that the actual number may not necessarily be as important or as significant as it is at the how fast it's the rate of climb of that temperature that sometimes gives us a stronger indicator that maybe the seizures may be because of the fever. What about a seizure history? What about previous seizures? And it would be a good idea to ask, is this similar? Is this new? Is this something that this child experiences? That may give us a little bit of indication as far as are the parents familiar with this particular situation, or are they, or is this the first time they've ever experienced the seizure with their little one? We may also be able to get a little bit of information as far as, are they taking any medications for the seizures? And if so, it would be a good idea to ask just a few questions along the lines of, did we have any changes with the medications recently? Did we change the dosage? Did we change the kind of medication? Those types of things. Sometimes these seizure patients can be kind of finicky. So any little alteration in their medication or their habits or their lifestyle could put them in a situation where they are more likely to have a seizure. So kind of keep those things in mind when you are just looking at and considering somebody who's having a seizure. So the causes of seizures, there could be quite a few of these. And the number one that tops our list on this particular slide is your fever. Again, we're not necessarily seeing that just the individual number itself is as important as it is as far as how fast they got there. So an infection may create a situation where you have an increase in temperature, increased fever, and so forth. That on top of the possibility that maybe they're in septic shock, but there's a tie-in with maybe an infection. What about meningitis? A couple of things like meningitis could create an issue where the brain might have either an insult or a disease process, and you could actually have a seizure from that. Obviously, poisoning is a big situation that you could that you would have to consider with any kind of seizing pediatric patient. What do they get into? Metabolic disorders, bleeding in the brain. So bleeding in the brain could be either spontaneous or it could be traumatic. But again, that may lead to some sort of a neuro disorder, a hypoxic event, pressure, you name it. A lower level of the anti-seizure medication, we kind of touched on a previous slide. Maybe something with their medication has changed, maybe a dosage, something along those lines. Then we have the hypoglycemia, so that would be your low blood sugar. That has been loosely associated with some of these seizing patients for whatever reason, that they may have this low blood sugar. On that particular note, it is also possible that we could have a seizing patient with a low sodium concentration. So hypoxia would be that low oxygen type of a situation. So as the brain becomes anoxic, then we could actually have some neurological dysfunction and some of the firing, which comes across as that seizure. And then, of course, we have a lot of these seizures that are what we call idiopathic, which just means we don't know. So it could be a seizure of unknown origin, or fever of unknown origin that results in a seizure. And so we have a seizure of unknown origin, if you will. So seizure treatment. What are we going to do? So obviously, let's make sure that we have a patent airway. We want to ensure the position, make sure that we have a patent airway, make sure that we don't have any obstructions if that is possible. High concentration oxygen is a good idea. Once again, to build up that buffer, to make sure that we are not going to become hypoxic, or at least make every effort to prevent hypoxia. Ventilate, especially if we are in arrest. So respiratory distress, I think it's helpful to go ahead and assist ventilation, but a full ventilatory support will be required for those in respiratory arrest. And obviously, request ALS and or notify the emergency department in advance so that they can have equipment and personnel available to help out with these little guys. So altered mental status. Let's talk a little bit about the causes. So hypoglycemia, again, that would be your low blood sugar. Poisoning, post-seizure, that would be your post-ictal type of a state. Infection, head trauma, hypoxia, hypoperfusion. So the slide mentions the AEIOU tips. This is a neat little way to kind of remember some of the causes for altered mental status, where the A stands for like alcohol intoxication or acidosis. We can consider both of those. The E can remind us to think about like epilepsy, so maybe that's a seizure type of a situation. The I would remind us to check for infection or consider some sort of infection going on. The O may remind us to double check and just see if there are any overdoses, whether or not drug or alcohol, anything along those lines. U, that's the one that we normally forget about, and that's U for uremia. And normally that's making reference to like kidney failure, those types of things where we have a buildup of toxins. Thank goodness that's not real super common with the pediatric patient, but it's good to kind of just remember that in the little saying here. The T is for trauma or maybe even a tumor. The I is for insulin. An easy way to remember that would be your hypoglycemic patient, the low blood sugar. P for psychosis, and then S for stroke. Again, it's a good thing to kind of consider. We don't see a lot of stroke with the pediatric patients, so the AEIOU tips can be something that kind of crosses over the majority of our patients with a fair amount of applicability But just kind of keep in mind that normally we don't see the uremic type of a situation and or the stroke type of situation with this patient population. Let's talk about the treatment of altered mental status. So you have this patient, maybe they are altered, maybe they are unconscious and unresponsive, or maybe they're just lethargic, but ultimately they have some altered mentation going on. So step number one, we sure want to make sure that we have a patent and clear airway. Of course, you are an expert with airway management at this point, so I understand the importance of that. High concentration oxygen. So we'd want to make sure that we are providing and assisting with the oxygenation as much as possible. Ventilate as needed. So provide ventilatory assistance and or maintenance as needed. Again, I hope at this point you kind of consider yourself as an expert with airway management. Check the blood sugar. Do not forget to check the blood sugar. Maybe there's something that we can do for that depending on where you work and the tools that you have handy. Try to get a good history. Maybe by obtaining a good history, it might be able to give us some insights. Maybe we could answer some of the questions regarding the AEIOU tips, and maybe that'll open some doors for us to try to figure out what's going on with this altered mental status patient. Obviously, transport. Wouldn't want to leave these types of patients out on the road. Poisoning, another common reason for pediatric calls. A couple of things that we'd want to just kind of consider for these pediatric poisoning type situations. Try to get a really good history. What was taken, how much was taken, how long ago, what treatment was given prior to EMS arrival. Those types of things I think are going to be instrumental in trying to figure out the path that the treatment needs to take. So if you can, bring a sample to the hospital. That's not always possible, but if you can, that'll provide a little bit of insight. And that may also help you to answer some of the questions when you call poison control to help out with these patients. The treatment for poisoning, especially with these pediatric patients. Number one, assure a clear and patent airway, high concentration oxygen, and assist ventilations as needed. I hope by now that you feel like you are an expert with airway management, oxygen delivery, and so forth. So this should be just kind of a routine thing for you right now. Obviously, you want to transport these types of patients and contact poison control. Give them a heads up, let them know what you have. And oftentimes, the folks at the Poison Control Center can provide instructions. They can give you some insight, maybe a few things to watch out for during transport, especially if the patient may have taken something like a TCA or a couple of the medications where you may have little to no warning before the patient just goes unconscious and unresponsive and deteriorates in front of you. So contact Poison Control, get them on your side, and they'll help you out. It's a great resource. So we can talk about the fever now. It's a common reason for pediatric calls. Sometimes the parents, especially some of the newer parents, first-time parents, get a little excited about their little one spiking a fever. So it's not uncommon for us to get a call out for a youngster that has a fever. And just keep in mind that the fever in and of itself is rarely life-threatening. It's usually a result of some sort of infection somewhere. Sometimes that could be meningitis, especially if there's a rash. Big thing with that is just remember, just transport, be calm, cool, collected. Watch out for the seizures. Again, when it comes to fever, and it's specifically febrile seizures, it's the rate of increase that is more significant that results in a seizure rather, than the actual number itself. So what about these hypoperfusion states? Again, this would be your type of patient that might have an issue with hypovolemia or some sort of a situation along those lines. A couple of the common causes of hypoperfusion, especially when it comes to hypovolemia, might be vomiting or diarrhea. Don't forget about your trauma. If they've lost a lot of blood, that could also contribute or lead to a hypoperfusion type state. And your infection. So if we go into septic shock, again, septic shock may be a situation where we have massive vasodilation, we might have some fluid loss and so forth, but ultimately we end up in a hypoperfused state. A few of the less common causes that are listed on the slide here that make reference to this whole hypoperfusion type of state. What about an allergic reaction? So that could be like your anaphylactic shock, again, where you have this massive vasodilation and you end up with a hypoperfused state. The poisoning type patients and of course a cardiac event could lead to a hypoperfused type of a patient, especially if the cardiac output starts to suffer. Whether or not it's a heart-related issue or it could be a traumatic insult, those all could lead to that hypoperfusion type state and could be detrimental. Signs and symptoms of hypoperfusion. So according to this slide, we have a rapid respiratory rate. That may be a situation where the patient is trying to increase the oxygenation by just being able to pull in extra air and or offload extra CO2, extra ventilatory rate there, extra minute volume. Pale, cool, diaphoretic skin. As the patient goes through this process, there may be some shunting that is involved. So we may have some clamp down, so your peripheries may be pale and cool, maybe even diaphoretic. That kind of goes hand in hand with the weak or absent peripheral pulses. What about a delayed capillary refill? That may be an ominous type of a situation. Very easy to detect, and here lately we've kind of called the reliability of the capillary refill kind of in question, because of a couple of factors that could just really make that an unreliable sign, such as temperature. Maybe they've got an underlying issue that creates a delayed capillary refill as their baseline. What about decreased urine output? So as the kidneys become hypoperfused, they don't perform as well. They don't produce as much urine, so it would be a good idea to ask how many diapers per day. How often are they urinating? And if the mother or father, if they're able to, ask them, have they been urinating the normal amount, or have they seen any striking difference over the past day or two, or even a couple of hours? And then again, another thing to kind of look out for is if the patient is crying but there aren't any tears, that might be something to kind of consider. You can also look in the mouth and determine whether or not the mouth is a little bit more dry than what you would expect. Those could be kind of put together and combined and kind of give you an idea that maybe we're low on fluid and we're experiencing some sort of hypoperfusive state. The treatment for this hypoperfusive state, once again, let's start off with the airway. Let's assure that we have an open and patent airway. Provide oxygen, be prepared to ventilate. Okay, so those are basic. That's what we've been doing quite a bit so far. For this particular patient, if it's a trauma patient, we're losing a lot of blood, let's control the bleeding, elevate the legs, let's keep them warm. Don't forget about spinal motion restriction if needed and or indicated. Obviously, we were wanting to transport this patient. If or when possible, gather a detailed assessment and or history on the way to the hospital. You wouldn't necessarily be able to justify sitting on scene to gather information that may take a while to get and or may have questionable benefit to helping this patient live. So we would gather what we can and do a good detailed assessment en route and gather history from the parents as much as you can. But try to do that en route, not necessarily on scene if you can avoid it. Near drowning. So a little bit of background about near drowning. This is the situation where the patient almost drowned from water suffocation. A lot of times these patients, we can pull them out, we can start helping them to ventilate and so forth, just to unfortunately have them die a little bit later. So there are a few things that we want to think about or talk about when it comes to near drowning. First of all, what else is going on? So consider the possibility of trauma, consider the possibility of hypothermia. So were they cold? Was this a cold water submersion? As far as trauma is concerned, did they fall? Did they hit their head? Or were they beat and then dumped? Who knows? But consider the possibility of trauma, consider the possibility of hypothermia, consider the possibility of some sort of agent like alcohol, especially for the adolescents. Adolescents, alcohol and water, they do not mix, so be just aware. As far as the treatment is concerned for some of these near drowning type of patients, first and foremost, let's protect that airway. Let's suction as needed. Let's ventilate if and when possible. And then let's get them to a hospital that's capable of managing airway, managing maybe the infection, managing the hypoxia, and so forth. So these are the types of patients that preferably would go to a children's hospital, that they're able to provide specialized care for the pediatric patient. So now we've got the sudden infant death syndrome, SIDS. This is an unfortunate case. It's kind of scary when you think about it, but it unfortunately occurs. So SIDS is defined as sudden death without identifiable causes in an infant that's usually less than 1 year old. The cause is not well understood. And most commonly, you'll get the call out first thing in the morning. In these particular situations, I think it's really important to remember the parents and the family should be considered your patient. The care that you can render needs to kind of transition to make sure that the family is taken care of. Whatever issues that they have in the short run, try to address those. Be very compassionate and understand that many of these types of situations, at some point, the family members have a tendency to kind of blame themselves. So be very aware of what you say. Be very aware of some of the nonverbal communication. These are awful situations, and depending on the particular case and location, you may not even transport these patients. These are the types of situations where you might just get called out for verification, and then you remain with the family until the justice of the peace and so forth arrive. And that concludes our short presentation over the pediatric medical emergencies. So if you have any questions, feel free to reach out to us, and I hope you have a great day. Bye for now.